everybody. I think we should get our afternoon session started. So I'm Jackie. I'm from the Brain Cancer Group. I'm the head of operations and research that's part of this charity. We're a brain cancer charity that is focused on raising funds for research, education and support initiatives for brain cancer patients and carers. And we're really proud to be co-hosting today's forum because we know that it's really important that patients and carers have access to information and really goes to empower how you make your decisions. We have an excellent lineup of speakers this afternoon. We have 4 in total, covering a range of topics such as the role of the care coordinator, clinical trials, psycho-oncology and supportive care. And without further ado, I'll introduce our first speaker, which is Marina Kastelan. Marina is a neuro-oncology nurse practitioner at the Brain Cancer Group, and she has been a registered nurse for over 30 years. After completing a degree in health sciences nursing in the 1990s, she went on to gain experience in intensive care and oncology, working in Sydney, Brisbane, and the UK. Marina has also completed an acute care certificate, oncology certificate, diploma in business management, and finally a master's in nursing, qualifying to be a nurse practitioner in 2017. She sat on many committees, including Cogno and the Expert Advisory Panel for the Medical Research Future Fund's Australian Brain Cancer Mission, and this mission aims to double the survival rates and improve the quality of life of patients with brain cancer. Her passion is in supporting, advocating, and educating patients with primary brain tumours and their caregivers. And Marina today will be speaking to us about the role of the care coordinator. Please welcome Marina.
That's right. I was going to get chopped back a bit. Okay. Hello. So I'm going to go through what a care coordinator is, and hopefully most of you have access to a care coordinator because this has changed somewhat over the last 10 years or so, which is really good for patients. Okay, so this has changed a little bit now, but the minority of brain tumour patients have a dedicated care coordinator. The majority don't, but this has changed over the last few years, which is great for patients because it was something that was really needed in the past where patients and carers were struggling a little bit with navigating the system. So the Brain Cancer Group, who I work for, were the first group to see the importance of supporting a dedicated neuro-oncology care coordinator. And yeah, so for a while I was probably one of the few around. So just to go through a little bit of the presentation of a patient and why it's important to have a care coordinator. So lots of these things that you may all know where the diagnosis is out of the blue, patients present with headaches, balance issues, sleepiness, seizures, vision changes, word finding changes or personality changes or confusion. Can be any or you know, a few of these sorts of things. And a big impact for some patients is around the cognitive functioning. So poor short-term memory is pretty common, a difficulty with comprehension and understanding pathways, sometimes irrational thinking, lack of insight, and sometimes patients have difficulties in the ability to plan, make decisions, and realise the importance of certain tasks. So sometimes the motivation and an initiation for important tasks has gone out the window. Things like where, you know, a patient has been in charge of updating the licence on the car or the rego on the car, and all of a sudden the carer's driving around in an unregistered car. It just puts a lot of extra pressure on the family as a whole. So as I said, it's a diagnosis out of the blue. Sometimes the information that we provide's out of difficult to understand or absorb. The information's a different language, so a lot of the time where we think we're speaking in, you know, simple terms, when you're using words and language and phrases that aren't common, you kind of think, what are they talking about? And the information can be overwhelming. There's big difficulty navigating the system with multiple teams involved, sometimes between multiple hospitals, different care facilities. So it's a bit hard to keep on top of everything. And obviously the, no driving factor when you've been diagnosed with a brain tumour. So you're reliant on family, friends, caregivers, whoever's around. So patients and their carers describe the process as a bewildering maze of confusion initially. And a lot of the time when I meet people, they're already, they're just after surgery, they're still on a lot of anti-seizure meds that are changing the way they think, they're on a lot of steroids, which, makes you not sleep, and so all of those things compound to make, the whole process pretty complex. So the complexity of cancer diagnosis and the treatment and the broad range of settings in which cancer care is delivered means that the care can be often be disjointed, and as I said, some people are going between multiple centres. So just to come back to that neurocognitive change, because I think this is a big thing as well, like just the change in language, speech, memory, mood, thoughts, content, personality and behaviour, let alone mobility changes, vision changes, all these other things. So then we get to care coordination. So what care coordination is to enable an easy supported pathway of care for the patient with improved and timely access to services and health professionals. And I think the timely access is a big one, especially when you've got an aggressive brain tumour. So it's where care is delivered in a logical, connected and timely manner so that the medical and personal needs of the patient are met. I just wanted to bring up here the importance of or unique role of a carer. I heavily rely on the carers. I tend to obviously try and include them in everything from the beginning because there's a lot of information, as I said, different words, the patient's on a few drugs that they haven't been on before, changes in thinking and that sort of thing. So big pressures probably put on the carer sometimes, and we know that there's sometimes an onerous care burden, and the carer's got a very important complex role. And we talk about carer mastery, and I am big at trying to educate the patient and the carer about changes that potentially can occur and how they can control the situation a little bit when they're in a completely out of control, environmental situation that it is. We do see some burnout with carers and try to support that as much as we can. We try and address the psychological and social well-being of the carer, plus the patient, as well as the carer and the family. A lot of patients that I've got teenage kids, so it's a disease that affects everybody. A lot of the time the carer is having to reduce their hours of work, or they're doing their full-time work plus the kids, plus the house, plus the care needs as well. So you can see why there's a big burnout amongst caregivers. A lot of the time the patient may be a big income source, so all of a sudden when you don't have that income support and you're relying on disability support, pension or some other Centrelink funding, it can be tough. And I find that the financial stress can be one of the hardest. If people can't pay their bills, can't pay mortgage, it just adds a lot onto what's already a difficult situation. And going back to that no driving, so all of a sudden you've been diagnosed with this disease but you can't drive yourself to the hospital each day, which can be different for other tumour groups. If you've got other tumour streams, you tend to be able to still drive yourself in for treatment. And then the frequent clinical visits, we try to consolidate things so that they're all together, but obviously during your radiation and that part of things, you're coming into the hospital every day and you've somehow got to get yourself in there. So nursing's all about holistic care and promoting quality of life. I think we think a little bit differently, or we were trained to think a little bit differently to the medical teams sometimes. A lot of what we do is around providing clinical care advice, support and counselling. When I started in my role back in about 2008, I think it was, I didn't realise how much over the phone counselling I did, and I'm not sure I was really prepared for it back then either, you know. But a lot of what we do is you know, where a patient will go in and see the doctors, and then you're getting family or patient wanting to talk to you about that consultation afterwards. So there's a lot of that going on. We're looking at psychosocial assessments and trying to get patients into clean psych, so to the professionals that can provide the services. Sometimes that's a challenge. Sometimes people prefer to talk to their direct care people, as in the medical and nursing team, rather than go see a third person, but definitely helps. A lot of referrals to allied health, social worker, physio, cancer council, and the support groups like BTAA. I think the biggest thing or the biggest feedback that I will get from patients and carers a lot of the time is that there's somebody there to answer the phone. You know, I'm not always there to answer the phone, but I do try. But, you know, there's one point of contact, and it goes back to that, where the patient or the carer isn't having to retell their story over and over again. I'm Bob, I live on the South Coast, I've got this. I know the patients and I remember them, and I've been in the role for quite a while that, you know, I say to people, yeah, I know who you are, you know, that's okay, you don't need to tell me that again. And I think that is a big part of it as well. And a massive thing is just the continuity of care. I know what's happened to the patient, you know. It's not a different nurse or a different medical person that you're going to each time. I know the medication changes, and I think that's a really big part of it as well, you know. Yeah. So what is care coordination? Encompasses multiple aspects of cancer care delivery. So you're trying to get everything in and support the person's whole being. So we do a lot at these multidisciplinary team meetings. There's a robust discussion, let's say, at these team meetings, which is good. And for me, the patients that we take to the MDTs, for me as a care coordinator, getting that pathway that I know that the medical teams are on this, you know, that particular page for the patient. Early intervention to medical staff, a lot of the time, part of the reason I became a nurse practitioner was because I'd have to run over, get a script, say to the doctor, this is happening, you know, what do I need to do, when I kind of knew what we were going to do in the first place. So part of the reason for me becoming a nurse practitioner was, you know, being then able to write the scripts myself, order tests in collaboration with the team. That's a big part of it. You can't do this role, you know, in silo. Because things change, and things change pretty quickly from a symptom point of view for patients. We do a lot with data collection, development with common protocols, be on committees, education, loads of education with patients and carers about the symptoms and how to manage symptoms, and then individualised clinical treatment as well. So it's a complex care pathway, as I keep saying, sometimes through multiple centres. So all of these people tend to be involved, you know, in the pathway. So you end up having a lot of people at some point, and it's enabling the communication between all of these people. So care coordinators, central to the communication and coordination of all healthcare professionals, providing a link to support the patient and carer. This is terrible, but where I work, I often say that I herd the cats, because it is a lot of trying to get a collaboration between a busy team of medical professionals and communicate that to the patient, you know, and making sure that everybody's on the same page. Care coordinators' names have changed over the years. We've had this nurse navigator. We're also educators, support providers. As I said, points of contact, can be a team coordinator, and we support the carer a lot. The models of practice, trying to keep people at home. Nobody wants to be in hospital if they don't have to be. you know, and I don't think anybody wants to be in hospital if they don't need to be. They're desperate to get out the door as soon as they can. So if you can try and support people and prevent them from coming to hospital, you know, that's great for the budget, great for the patient. A lot of collaboration with the GP, allied health, as I said, things like Vision Australia, Canteen, these extra services. The management is a complex management, as I said, holistic care, looking after the whole person. That early intervention is a big part, and as I said, I carry a phone, we do loads via email. You know, I often think of other medical oncologists who deal with patients with brain tumours, and if they don't have a care coordinator or somebody to just, you know, field some of the communication, they must be in their clinics till midnight, 2 a.m, trying to actually respond to people. So, you know, I think that phone contact, email contact is really essential for patients, and it's something that they need. But it's also in early intervention to things like when people do get things like pulmonary emboli, clots, signs of raised intracranial pressure, seizures, that sort of stuff. And obviously palliative care referrals. So care coordination specific to neuro-oncology is central to communication and coordination of all all health professionals, providing a link and support to the patient and the family. It's that bridge that you're trying to foster, I guess. So this is the aim of it, that the care is delivered in a logical, connected, timely manner so that the medical and personal needs of the patient are met, as well as the family and caregivers. That's the end of my talk. Has anybody got any questions, or do you want to ask something? Hello. Yeah.
Yeah, recently diagnosed, and I'm with RPA, Chris O'Brien, and I've asked for care coordination because I understood it was crucial, and they say they don't do it. So why some areas of CNA do it and some others don't?
Yeah, that's a big question. Maybe these two lovely doctors down the front can help me answer that one. It's been something that we've been working on for 15 years, you reckon, Liz, or longer?
I think it's been on the radar since 2001.
Yeah.
Look, I think that you'd find even at Chris O'Brien Lifehouse, there'd be general care coordinators. So there's some centres where there's not a specific brain care coordinator like Marina, but I would say that every large cancer centre would have a nurse coordinator that would specifically have brain tumours as one of the list. Catherine wants to say something.
We are presently the collaborative, all the brain tumour organisations in Australia have got together, and we have a collaborative. At the moment, we are lobbying government to get a voice. We've done it many times, and there's in the budget, I think there were, how many, is it 100 generalists?
I think historically, going back over the last 20 years though, there wasn't really a need because patients were taking tablets and they were in the community. They weren't, I suppose, like breast or lung cancer patients where they were being seen in clinics. So a lot of the care was floating around the community. So, you know, the need wasn't seen. And I know at North Shore, one of the med oncs that I work with, you know, was nearly going crazy with the work that they were needing to do to support people, and that's really how the role became about at North Shore. And over time, through BTAA and other groups, we've been trying to get the importance or the need of the role up and going. It's gotten a lot better. People like the Mark Hughes Foundation are now supporting about 4 people. The Brain Cancer Group supports me. As Liz said, there's generalists at Liverpool. But yes, some centres don't have a designated one, you're right.
And Marina runs a workshop every year to train up the general care coordinators so they can upskill in managing brain tumour patients. There have been submissions to the New South Wales Parliament at Liverpool Hospital, where Sue and I were. We actually did a clinical, like a research study to show the benefit of having a care coordinator in terms of money saved and admissions stopped. And that was a very positive study, but it is very difficult to translate into bodies on the ground. But it's something that we haven't forgotten about.
Yeah, and it is getting better. Okay. Thanks.
Thank you, Marina.